So let's talk about the OT's, the generalist OT's perspective on the assessment of vision and cognition, or cognition and vision. So from that OT perspective, the assessment of cognition, we are really looking at that functional context, how thinking skills translate into real world participation in tasks. So for example, cooking, managing medications, handling finances, being in the classroom, being at a job, performing simple home management tasks. What does that look like? How do we as OTs really focus in on that functional context to assess cognition outside of paper and pencil tasks that you might see a speech therapist or a neuropsychologist use? So we have some formal assessments for cognition, we have performance-based assessments for cognition, and we have that functional assessment for cognition. So specifically some standardized assessments that we might use. The MoCA, the Montreal Cognitive Assessment, this is an assessment that is, you need to be certified to administer this assessment. You will get that certification in further semesters. You'll actually get that paper, that credential. There is the Allen Cognitive Level Screen. This is another assessment that you will revisit in later semesters. The Cognitive Performance Test, the assessment of motor and process skills. That assessment you will be introduced to. That is an assessment that requires certification. It's like at least a weekend training that you go to be able to then administer that. The LOTCA, or the Lowenstein Occupational Therapy Cognitive Assessment, you will do that in another semester. Executive Functioning Performance Test and the Children's Kitchen Task Assessment. These both are free. They are available through WashU, and they were specifically, the EFPT was developed by Carolyn Baum, and the Children's Kitchen Assessment is directly built off of the style of the EFPT. And the Kettle Test is another functional standardized assessment that you might use to evaluate your clients. So in terms of that functional performance, that observation, we watch our clients perform real life activities to reveal how those cognitive impairments might manifest during the actual function. We also really want to be sure to gather a history about our clients' cognition. We want to know how they were performing before we are seeing them, and is that any different than how they are currently presenting? So really getting that client caregiver, care provider interview can be really important to know really what those differences are. And specifically, if you are working with a client who has cognitive impairment, what strategies were they using to help with that cognitive impairment, and making sure that you're using those strategies with them. Of course, doing a chart review to really understand what their diagnosis is and if it's expected that there is a cognitive component to it. So if it's a neuro component versus a gen med component diagnosis, we know that if it's a neuro diagnosis, anticipate potentially seeing a cognitive component. If it's a gen med diagnosis and it's not typical to see cognitive impairment, doing that deeper dive into why you might be seeing what you're seeing. So remembering that we do not assess cognition or anything in a vacuum, so we need to factor in different things, and this is not an exhaustive list. So thinking about the environment. Is the environment familiar or unfamiliar? And that could really change how the client performs, specifically your pediatric clients. If you are working with somebody in a school setting and you pull them out of the classroom to perform your assessment, your evaluation, that cognition might be very different because they're out of their familiar context. working with somebody in a skilled nursing facility, working with somebody in the home, like taking in those environmental contexts can really dramatically impact performance. Thinking about the time of the day and how tired somebody is, or if they've had medication, because cognition can also often fluctuate depending on those factors. If somebody's just newly had a surgery, and depending on their age, that anesthesia might have a longer lasting impact on their overall cognitive performance. Thinking about the sensory and motor factors. So if you have a client who has a premorbid vision, hearing, or motor impairment, this could impact your cognitive testing. So if you have somebody who has a hearing impairment and you're asking them a whole host of questions and they're not responding, that could be confused with a cognitive overlay. But it is in fact that they just don't have their hearing aids. If you have somebody with a motor or visual impairment and you're doing a paper and pencil task, they might not perform to their exact ability because of those factors. Cultural and educational background could also impact test performance. So really understanding if you're doing an assessment and somebody has never, somebody does not have a high school degree, or they don't do certain cognitive tasks because it's not expected of them based on their culture or their education. And considering their emotional state, depression and anxiety can certainly impact somebody's cognitive performance presentation. So what are we assessing? We are certainly assessing across the spectrum of cognitive domains. And these are all interconnected. Cognition does not necessarily live by itself. All of these components don't live alone. They all work together. And if you have an impairment in one area, you will see that it impacts cognition across the board. So for example, if you have a client with impairments with attention, sustained, selected, etc., if they're having trouble focusing or difficulties focusing on the task and are unable to filter out distractions, that could then directly impact their ability to lay down new memories because they're not focusing in on the activity. I think we can all, maybe we can appreciate that from the perspective of when you're feeling stressed or overwhelmed, maybe your attention isn't as good and you're having a harder time laying down memories of what you've read in a textbook. Or if you're fatigued or tired, it's hard to pay attention. Or if you don't feel well, it's hard to pay attention. If it's hard to pay attention, then maybe you're not laying down memories. Thinking about that executive functioning, planning, sequencing, problem solving, initiating, how all of those are directly interconnected and how that can influence cognitive presentations. Processing speed, how quickly somebody is responding to you. So this could be from that perspective of being on medication or being fatigued or being stressed or having just woken up from a nap. Processing speed might be delayed, and how quickly somebody is responding to you, they might need more time. And based on needing more processing time, that could be misinterpreted as somebody with a cognitive impairment. So really just being mindful and thoughtful and aware of what factors could influence cognition and what is in fact a cognitive impairment and what is based on other personal factors, and then how you can evaluate that, document that, and then provide intervention for that. Orientation, awareness of person, place, time, situation. In terms of time, I think it's not always fair to ask somebody to be exactly clear on what the date is or the day of the week. I think in our current time frame of life, most of us have, many of us, me included, have a hard time remembering what the exact date is without looking at my calendar or a watch. So just kind of keeping that in the back of your head, what is realistic in terms of orientation. But there are some factors that we should be able to pull up, like, about what time of the day is it, or about what time is it, what day of the week is it, maybe not the exact date, but what day of the week is it, what year is it. Asking situational questions can be very telling, like, where are you? Why are you here? And as I've said before, and you've probably heard before, don't ask a question related to memory if you don't know the answer. Perception can certainly impact cognition. Visual processing, figure ground, if you're asking somebody to do paper pencil tasks or doing a kitchen tasks, and there are challenges with body awareness and visual processing, this could have a impact on cognition. And insight and awareness says if somebody is aware that they have deficits, and this is one of the hardest things to treat. If somebody doesn't have insight, it's hard to give somebody insight if they don't know that they have impairments. So being able to understand that, is this insight and awareness into impairments, and then how to craft your interventions, your evaluation and interventions to address that. So the goal of the eval is to determine functional capacity and safety. Can this person live alone? Can they drive? Can they manage finances? Can they function in the classroom? Can they go back to work? Can they insert thing, how you're using the data from your evaluation. This allows you to identify compensatory strategies or environmental modifications. So if somebody is going to be going home alone, but they maybe have some memory changes, setting up some maybe strategies on the phone, or check-ins for the family, or check-ins from neighbors, or checklists, or insert or like, what are these strategies or modifications that you're making recommendations for, and documenting. This absolutely guides your treatment planning and your goals, and it can also inform the broader care for the client, and certainly it is critical for your discharge planning. So, OT's perspective on vision. Again, going back to that function, we are really looking at functional cognition, how the eyes and the brain work together to support occupation. We oftentimes will work closely with optometrists and ophthalmologists to really focus on the functional implications of visual impairment. So if you have somebody with neurological dysfunction, visual impairments related to neurological condition, you might work with a neuro-optometrist to do for assessment and treatment planning. You might work with an optometrist or ophthalmologist if you have somebody who needs glasses. So we do certainly work with those professions. And we're really looking at how vision is impacting ability to engage in occupation. So again, from that generalist perspective, we want to start with some very basic questions, such as testing, do they have their eyeglasses? Do they wear contact lenses? These are crucial parts of your assessment. Testing environment should be well lit. Without my reading glasses, it's hard for me to read some smaller text when it's a little bit dim. So that could look like a functional visual impairment without my reading glasses. So making sure that I have the tools that I need to perform these activities, or visual testing. So you want to make sure that they have their glasses and they're wearing their glasses. Know if they have a neurological involvement, or if it's a low vision involvement. And low vision could be from an acuity perspective, or it could be from premorbid conditions such as glaucoma, cataracts, macular degeneration, diabetic retinopathy. So asking those questions as well, because those premorbid conditions, low vision, not having their glasses, those can all impact their presentation and how they are presenting during visual testing. So what does visual testing include? Visual acuity, so the clarity, sharpness of vision at near, far. Visual field, the full extent of what a person can see without moving their eyes, so your quote-unquote peripheral vision. And there are some complications following stroke or other neurological conditions, or premorbid, maybe suppression of a quote-unquote lazy eye, or somebody who had strabismus as a young child. So you're going to be testing oculomotor function, so their visual field, their kind of peripheral vision, oculomotor function, how well are they able to move their eyes, how is the optic nerve functioning, the oculomotor nerve. So doing rapid eye movements, which can really impact reading and scanning, being able to follow a moving target, sustaining visual fixation, and converging or diverging, how your eyes work together for depth perception. So visual perception, how the brain interprets and makes sense of visual input. These terms are often really related to that visual perception, specifically with your children in schools and outpatient, so how that brain is interpreting visual information. But you also might see somebody who has impairments with figure ground, visual closure, visual spatial relations, who've had a stroke or a brain injury. So also remember, our clients don't live in voids. They have prior medical history, so you might be working with an adult who as a child had visual perceptual challenges and have learned to compensate. So understanding what those compensations are and being able to document that accurately, and understanding how that could impact the results of your evaluation. So visual attention and scanning, contrast sensitivity, how somebody's able to detect the difference between light and dark. So this is really impactful during low light environments, reading low contrast text and navigating stairs. So somebody might not be able to read in a lower light, or they might not be able to read if their font isn't bolded or enlarged. They might not be able to read your instructions in a distracting environment. If there is that subtle contrast sensitivity going up and down the stairs when there's low light, they might be at a higher risk for falls. So these are all things to consider during your evaluation. Somebody might have a light or glare sensitivity after medications, if they've been in the hospital for a prolonged period of time, maybe in an ICU, they now maybe have some level of photosensitivity and difficulty adapting to changes in light, which could certainly impact community mobility and how they're using their phones. And then here are some standardized assessments. Some of these you have been exposed to and some you will be exposed to later on. The Snellen acuity chart, confrontation testing, so doing your visual field testing, the MVPT, the DTVP. You've been exposed to Warren's visual hierarchy of visual skills, from what you need at the very basic foundational level to be able to perform more higher level vision and cognitive tasks, the Bell letter cancellation test, and Catherine Burgago scale, looking at functional neglect during occupation. So some ways that you might observe some visual impairments are during those functional tasks, right? That's what we're really looking at. We can do confrontation testing. We can use the Snellen chart and get a baseline of what their ocular motor nerves are doing, functioning, or what their acuity is. But functionally, why does this matter? Are they able to read a newspaper or your name tag or a schedule or their phone or a medicine bottle? Are they able to have the depth perception to pour liquid from one cup to another? Are they able to navigate hallways and stairs? Looking through a cluttered drawer, pulling out clothes from a closet? Are they able to use their contrast sensitivity or depth perception or visual closure to complete these activities? Are they able to use their computers? So using your occupational analysis to break down tasks to help really pinpoint what those visual components are, that might be contributing to difficulty. We talked about this. You doing an ocular motor health screening, make sure that you know what their premorbid function is and if they have any new onset of visual changes, such as nystagmus, so uncontrolled beating of the eyes, double vision, eye fatigue or headaches. If the pupils are not responding equally, that can really impact light sensitivity, how the eyes are working together, and that can impact depth perception. And making sure you're referring to an eye care specialist as appropriate. And we talked about this a little bit, but really making sure that you're setting the context and the environment up for your client for their ultimate success. So do they have adequate lighting? Can they actually do the task that you have recommended? So my visual system might be very different from somebody who does precision work. So I might not be able to participate in a vision screen that you're providing me if my visual system doesn't need the demand. So being aware of providing the right assessment to get the data that you're looking for. There might be a cognitive overlay, so your client might not be able to describe what it is that you are asking, and so being aware of that and making sure that they have the tools that they need for success. Going back to, again, this population-specific considerations. If you're working with somebody with a stroke or brain injury, they might have ocular motor dysfunction, visual field impairments, cortical visual impairments. Your pediatrics might have developmental visual perceptual delays, low vision, just general aging changes. Other neurological conditions such as MS or Parkinson's, those might have specific disease-related visual changes. And what are your goals? Finding will drive your intervention plan. They will drive your referral decisions. They will drive your equipment recommendations. They will drive safety recommendations, and they'll drive your patient and caregiver education. So in terms of intervention planning, is it environmental modifications? Is it adaptations? Is it just recommending go to the eye doctor? Is it recommending that they have a follow-up because of their diabetic retinopathy? Making recommendations for a neurooptometrist or low vision specialist. Adaptive equipment recommendations such as a reader, a magnifier, a lighting adjustment, color components such as like a bright strip on the left of the screen so that the client has to find that as a anchor to then read left to right or right to left depending on what language they speak. Making safety determinations, recommending if they're a fall risk and adaptations and environmental modifications. Can they drive? Can they live independently? And all of that boils down to all of the education that you provide. So document everything that you see and breaking all of those components down using your occupational analysis. So I hope that was helpful. And as always, don't hesitate to reach out.